Good evening, consultants, fellows on the call, and colleagues. Welcome you to today's discussion. Today we have Dr. Ogeke Linian to present to us on the topic aortitis, aortic aneurysm, and aortic dissection. Dr. Ogeke, please, your audience.
Okay. Can you hear me? Hello.
Yes, we can hear you.
Okay. Consultants and colleague, I'm Dr. Ogoke Lilian, and I'll be discussing aortitis. It's supposed to be pathophysiology of aortitis, aortic aneurysm, and dissection with the following outline. Okay, so a brief anatomy of the aorta. The aorta is the largest artery in the body and is divided into four sections: the ascending aorta, the aortic arc, the thoracic or descending aorta, and then the abdominal aorta. It terminates at the level of L4. Now, for the ascending aorta, it has the aortic sinuses, the right and the left sinus, which gives rise to the coronary arteries, and is about 2 centimeters long. Then the aortic arc ends at T4, and it gives rise to the brachiocephalic artery, which is the largest branch. And the brachiocephalic artery also gives branch to the right coronary and the right subclavian artery. Now, the right subclavian artery supplies the right upper limbs, while the right coronary artery supplies the heart. The second branch of the aortic arc is the left common carotid artery. The third is the left subclavian, which supplies the left upper limb. And then the third branch of the aorta is the descending aorta, which rises from T4 to T12. And these branches include the bronchial arteries, the mediastinal arteries, the esophageal artery, pericardial arteries, the superior phrenic arteries, and intercostal and subcostal arteries. Then we get to the abdominal aorta, which starts from T12 to L4. And it gives the inferior phrenic artery, the celiac artery, superior mesenteric artery, okay, and other branches. Now, for aortitis, is a histopathological diagnosis of inflammation of the aorta. Is a representative of a cluster of large vessel diseases that have various or unknown etiologies. And then the most common causes are infectious, immunologic, or connective tissue disorders. Now, inflammation of the aorta can cause aortic dilation, resulting in aortic insufficiency. Also, there is fibrous thickening of the aorta and osteostenosis of major branches. Agents that are known to infect the aorta include the Neisseria gonorrhea, TB, Rickettsia species, spirochetes, and that's the syphilis fungi, and some viruses like herpes virus, varicella zoster virus, Hep B and Hep C. Immune disorders affecting the aorta include the Takayasu arteritis, giant cell arteritis, polyarteritis nodosa, Behçet's disease, and others. While there is anti-neutrophil cytoplasmic autoantibody disorder that can affect the large vessels, and this is seen in Wenner's granulomatoses and polyangiitis Church-Strauch syndrome. Other antibodies, such as antiglomerular basement membrane, like the Goodpasture syndrome, Kawasaki disease, can also be culprits. Transplant rejection, inflammatory bowel disease, and paraneoplastic vasculitis may also afflict the large vessels. Now, for pathological phases of aortitis, it has three phases. The early inflammatory phase, where there is which is characterized by infiltration of inflammatory cells into the aortic media layer, causing the vessel edema and thickening. Then the second phase is a vascular remodeling phase, where there is destruction of the elastic fibers in the media. And then the last is the late ischemic phase, where there's narrowing of the aortic lumen due to intima thickening, and then there can also be thrombus formation. In advanced cases, occlusion of the vessels to extremities may also result in ischemic skin changes and ulcerations. Now, Takayasu syndrome, I will just take a few of the causes of aortitis. Takayasu disease is named after the Japanese ophthalmologist who first called the attention of the fundoscopic findings. It's seen mainly in young women, age of diagnosis between 25 to 30 years, and it has a predilection for brachiocephalic vessels. It's characterized by inflammatory granulomatous vasculitis of the medium and large vessels, leading to transmural fibrous thickening of the arterial wall and can also cause ischemic changes. Okay, aortic involvement is very common with angiographic abnormalities. The abdominal aorta is the most common site of involvement, followed by the descending thoracic aorta and then the aortic arc. Branch vessel disease is highly prevalent in Takayasu arteritis with subclavian, innominate, renal, common carotid, vertebral, and mesenteric arteries can also be involved. And there's a mutation in HLA-B and interleukin 12B, which suggests there's a predisposition to some genetic factors. In active stage, granulomatous arteritis is seen, and in later stage, it can cause degeneration of the media, of the intima media, fibrous scarring, and intima proliferation. Angiographically, the left subclavian artery is narrowed in approximately 90% of patients. The right subclavian artery, left common artery, and left carotid artery, and the brachiocephalic trunk follows closely in frequency of 50%, thoracic aorta in 66%, abdominal aorta 50%, and aortoiliac 12%. And symptoms appear in the second and third decade of life. Onset is in childhood, and the middle age has also been reported. Onset of illness by age 40 avoids overlap with the GCA. So upper extremity claudication, diminished brachial pulses greater than 10 limit of differences can also occur. So the presence of 3 of 6 criteria carries high diagnostic accuracy. Now, for giant cell arteritis, it involves extracranial arteries, which include the aorta in about 10 to 13% of cases. It causes narrowing of the brachiocephalic arteries, aneurysm of the ascending aorta. It can also cause aortic dissection and regurgitation. And it always occurs in people who are older than 50 years of age and can present with polymyalgia rheumatica and with temporal arteritis. So sometimes it can even cause blindness. Treatment of GCA involves oral prednisolone and induction steroids, which has also been found beneficial. In unresponsive cases, cytotoxic agents are used like azathioprine, methotrexate, and cyclosporine. Now, for an aortic aneurysm refers to a pathological segment of aortic dilation that expands and can eventually rupture. Now, when there's dilation, it causes an increase in the diameter of at least 50% greater than the expected for the same aortic segment in unaffected individuals of the same age and sex. It can be described by the size, the location, the morphology, and cause. Now, in adults, the diameter of the aorta is about 3 centimeters at the origin and in the ascending portion, 2.5 centimeters in the descending portion in the thorax, and 1.8 to 2.0 in the abdomen. The aortic wall consists of the thin intima, which is composed of the endothelium, subendothelial connective tissue, and internal elastic lamina. The tunica media, composed of the smooth muscles and extracellular matrix. And then the adventitia is composed of the primarily of the connective tissue, which encloses the vasa vasorum and nervi vascularis. Now, the aorta is distended during systole to allow a portion of stroke volume and elastic energy to be stored, and it recoils during diastole. So, owing to its continuous exposure to high pulsatile pressure and shear stress, the aorta is prone to injury and disease. So as one gets older, there is increasing stiffness that can occur at on the aorta. So for classification, we have the true and false aneurysm. Then the true aneurysm is a localized swelling that involves all the 3 layers of the vessel wall. That's the intima, the media, and adventitia. While the false aneurysm, also known as pseudoaneurysm, it involves the intima and the media layers. And the dilated segment of the aorta is lined by the adventitia only, and at times by perivascular clots. It can also be classified based on morphology, which includes the fusiform aneurysm, which affects the entire circumference of the segment of the vessel, resulting in a diffusely dilated artery, and the circular aneurysm, which involves only a portion of the circumference that results in the outpouching of the vessel wall. This is a picture of the circular aneurysm, the fusiform, which are true aneurysms, and then the false aneurysm. So the fusiform affects the entire circumference, while the circular affects just only a portion of the circumference. So aneurysm can also be classified based on location, the thoracic and abdominal aneurysm. Now, classification of the abdominal aortic aneurysm is based on location, which includes the suprarenal aortic abdominal aneurysm that starts above the renal arteries, pararenal, which involves the level of the renal arteries, juxta renal, and then the infrarenal, which occurs below the level of the renal artery. So this is a picture of the 4 types. Okay, let's start with the thoracic aortic aneurysm. The estimated incidence occurs in at least 5 to 10% and 5 to 10 per 100,000 persons per year. And then the parts that have been affected more is the aortic root or the ascending aortic aneurysm. That's the most common, approximately 60%. While 35% occurs in descending aorta and 10%, less than 10% in the aortic arc. Now, the thoracoabdominal aortic aneurysm refers to the descending thoracic aneurysm that extends distally to involve the abdominal aorta. It affects men more than females, so it's 2 to 4 times more frequent than females. Age of diagnosis is higher in women, and then it affects approximately 5% of individuals over 65 years of age, but it's still higher in men than women. For etiology, the aneurysm results from conditions that can cause degradation or abnormal production of the structural components of the aortic wall. That's the elastic and collagen, which gives elasticity to the aorta. Now, causes are broadly categorized as degenerative disorders, genetic or developmental disease, vasculitis, infections, and trauma. For degenerative disorders include aging, cigarette smoking, hypercholesterolemia, hypertension, and patients with atherosclerosis. Now, for genetic, it's commoner in patients with Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, Turner syndrome. It could also be familial and also bicuspid aortic valve involvement. For infections, commonly is seen in syphilis, TB, and mycotic infections. They're rheumatic. It can be involved with Behçet's syndrome, Cogan's syndrome, and idiopathic aortitis. Also pregnancy and then trauma. For aortitis can also lead to aneurysm, which is seen in Takayasu arthritis and thromboembolism. Risk factors for thoracic aortic aneurysm include smoking, hypertension, age, patients with COPD, patients with coronary artery disease, and family history. Also, there is cystic media degeneration, which describes the degeneration and fragmentation of elastic fibers, the loss of smooth muscle cells that leads to increase in deposition of collagen and replacement with interstitial cysts. So this is commonly seen in patients with Marfan syndrome and many other genetically triggered thoracic aortic aneurysm. For the inherited forms of aortic aneurysm, it constitutes less than 5% of patients with thoracic aortic disease. And common syndromes include the Marfan syndrome, which is linked to an autosomal dominant anomaly in genes that regulate synthesis of fibrillin type 1. Now, what's it called? And TGF beta signaling was identified as a signal. So it's a signal, and aneurysm involves this cyanosis of Valsalva and tubular portion of the ascending aorta. So patients with Marfan syndrome, the aneurysm involves the sinus of Valsalva and the tubular portion of the aortic of the ascending aorta. And the fibrillin 1 in Marfan syndrome leads to excess free TGF beta, which promotes aortic disease. Also, it has been found that angiotensin interacts with TGF beta signaling and blocking of TGF beta by neutralizing antibodies. So in patients with Marfan syndrome, and aggressive aortic disease, ARB therapy has been found to stabilize aortic root size. In Ehlers-Danlos syndrome is a inherited connective tissue disorder. This aneurysm is more frequent in the vascular type, that's type 4, which results in a mutation of the COL3A1 gene, encoding type 3 collagen. It's an autosomal dominant disorder with frequent involvement of the descending and abdominal aorta. Unlike Marfan syndrome and Loeys-Dietz syndrome, the abnormal arteries are friable and thus making surgical repair more difficult here. Loeys-Dietz syndrome is associated with aortic and arterial aneurysm that enlarge rapidly and are prone to rupture. This condition is characterized by hyperterorism, which is widely spaced eyes, bifid uvula, or cleft palate. It's characterized by rapid early onset of thoracic aortic aneurysms and has an early age of death, averaging about 26 years of age. Okay, it causes mutation in the TGF-BRO1 and TGF-BRO2, with TGF-BRO2 having more aggressive vascular phenotype than the TGF-BRO1. Patients with congenital bicuspid aortic valve also have a structural abnormality of the ascending aorta, and this may be a consequence of post-stenotic dilation. Now, for patients with familial thoracic abdominal aneurysm, they are traced to hereditary metabolic abnormalities affecting the aortic wall. So they follow a more malignant cause than sporadic form and presents with a younger age, and is found to expand more rapidly, about 2.1 versus 1.6 millimeter per year. Now, the genetic tests in patients with thoracic abdominal aneurysm include the FBN1, FBN2, that's the FBN1 seen in Marfan syndrome, the CoA, COL3A, and others. And these genes, also genes that encode proteins related to small muscle cells, genes related to the TGF beta signaling pathway. Okay, so we have classification of thoracic aortic aneurysm, which is a Crawford classification, and it has 4 types. Type 1, which involves the descending thoracic aorta from the left subclavian artery down to the abdominal aorta above the renal arteries. The type 2 extends from the left subclavian artery to the renal arteries. Type 3 begins at the mid to distal and descending thoracic aorta and involves most of the abdominal aorta as far as the thoracic bifurcation. While the type 4 extends from the upper abdominal aorta and all or none of the infrarenal aorta. So for pathophysiology of aneurysms, we have we have 4 main things that can lead to aneurysm formation, where the TGF-beta, which regulates aspects of, is involved in cell growth, smooth muscle cell proliferation, and matrix synthesis. They play a role in extracellular matrix homeostasis. So when there is mutation of these TGF-beta receptors or downstream signaling pathway, it results to defective elastin and collagen synthesis, which now reduces the elasticity of the and the sensibility of the aortic valve. So this is commonly seen in patients with Marfan syndrome, where there is defective synthesis of the scaffolding protein that leads to abnormal sequestration of the TGF-beta in the abdominal wall. I think I've talked about angiotensin II receptor blocking agents, and they are found to inhibit this pathway. So it has been found to help with patients with aneurysm disease. Other aspects of the role of TGF-beta in the regulation can be paradoxical, such as elevation, despite the loss of function mutations, leaving the true pathologic importance of this pathway. Also, there could be excessive connective and tissue degradation, where there is increased membrane metalloproteinase expression by the macrophages, and this leads to degradation of the tissue inhibitors of metalloproteinase, which has been implicated in aneurysm development. So as a result of this, the aortic wall undergoes protein degradation, resulting in loss of mechanical integrity. Also, the aortic wall has elaborate inherent mechanism to respond to ambient blood pressure and remodel in response support the view of the mechanism that protects the aortic wall from hemodynamic stress. And this can lead to destruction in certain inherited disease, leading to progression of aneurysm. Other extrinsic causes of aortic aneurysm include effects of pharmacological agents that have been linked to aortic aneurysm development and dissection. Drugs like fluoroquinolones, antibiotics, tend to cause signaling of the NTIMP, and which can lead to aortic aneurysm. Now, there's novel pathophysiology mechanism like the microRNA dysregulation. They said certain microRNAs have been identified to play a role in regulating gene expression, which leads to which is related to the extracellular matrix components, and this causes the vascular smooth muscle cell functions and inflammation potentially contribute to aneurysm development. Then changes in DNA methylation patterns are also found to alter gene expression, leading to vascular remodeling and inflammation. And also reduced nitric oxide production has been found to lead to increased oxidative stress, leading to destruction of the extracellular matrix. Now, for clinical categories of aortic aneurysm, the thoracic aortic aneurysm may be considered as two distinct diseases, which is divided at the ligamentous arteriosum. Proximal to the ligamentous arteriosum, there is aneurysm of the ascending aorta and proximal portion of the aortic arc, and they are smooth in contour, not calcified, and free of mural thrombus. While distance to that develop in patients who are at risk of atherosclerosis, patients with DM, hypertension, smoking, and the features are irregular contour calcifications, and they also develop mural thrombus. Now, the ascending aortic aneurysm are typically fusiform and often extend into the aortic arc. So the most common type, which is the supracoronary aneurysm, the aortic annulus is normal in diameter. The second category, termed the annulo-aortic ectasia, is characterized by enlargement of both the aortic annulus and the proximal portion of the aorta. And this is typical in Marfan syndrome and other related disorders characterized by cystic media necrosis of the aortic wall. While that of the descending thoracic aortic aneurysm, majority are atherosclerotic, typically fusiform, and often benign distal to the origin of the left subclavian artery, and then it can extend to the level of the abdominal aorta. For the abdominal aortic aneurysm, is defined by an abdominal aorta greater than 3 centimeters in diameter. It occurs in 3 to 9% of older people. Is 5 times more prevalent in men than women and strongly related to age. It's also strongly associated with smoking. It's also associated with chronic aortic wall inflammation, increased local expression of proteinase, and degradation of the structural connective tissue disease. The primary event in abdominal aortic aneurysm development is when there's a breakdown of elastin, which is a protein responsible for the aorta's elasticity. Also, neovascularization may form within the aortic wall, further contributing to tissue remodeling.
Add this and this. What you get, slice it by this. Whatever you get, slice it by 2.
Okay, so clinical features include it develops insidiously over years and rarely causes any symptom in the absence of distal thromboembolism. So the patient can come with pulsatile epigastric or periumbilical mass. They can come with syncope, anterior chest pain, or shortness of breath, which is seen mainly in ascending aneurysms, interscapular, mostly with descending aneurysm. Then from local compression, which is patient can come down with hoarseness of voice, early satiety, nausea. Then embolic phenomena like livedo reticularis, blue toe syndrome, and they can also come with fever. For ruptured abdominal aortic aneurysm, typical manifestation is abdominal or back pain with a pulsatile abdominal mass. They can also come down with groin pain, syncope, paralysis, and flank mass, transient hypotension, really when it's ruptured, shock that is also presenting with cyanosis, altered mental status, tachycardia, and a fistula when there's a rupture into the vena cava. Then they can also present with upper GI bleeding when there's exsanguishing hemorrhage. For investigations in aortic aneurysm, for chest X-ray, you will see a rounded shadow at the right upper mediastinal border, which may indicate an ascending aortic aneurysm. Findings also include widening of the mediastinal shadow and displacement or compression of the trachea on left main bronchus and enlargement of the aortic lump. Aneurysms involving the sinuses of Valsalva and aortic root may also be seen on X-ray, being hidden behind the sternum, mediastinal structures, and vertebrae. Also, thoracic echocardiography can visualize thoracic aortic aneurysm involving transthoracic echocardiography can visualize thoracic aortic aneurysm involving the sinus of Valsalva and often the proximal ascending aorta, while transesophageal echocardiography can be used to assess the proximal ascending aorta and the descending aorta. While on CT scans, the thoracic aortic aneurysm are characterized by an increase in the aortic diameter and outward displacement of calcium on the aortic wall. For patients with abdominal aortic aneurysm, abdominal ultrasound is the gold standard. It's 100% sensitive and about 96% specific. It's a non-invasive procedure, cheap, and no exposure to radiation. It's an excellent tool for screening and surveillance. Diameter measurement should also be performed in the plane perpendicular to the arterial axis to avoid overestimation. Then aortography can also be used for imaging of the length of the aortoiliac lesion and also collateral ovarian anatomy, location and severity of occlusive disease, and associated aneurysms in the viscera or iliac arteries. These patients, when they do CT or MRI, and MRI has emerged as a current investigation in the preoperative and postoperative evaluations of abdominal aortic aneurysm. CT is accurate in both detection. It's also used for the measurement of the diameter, involvement of the visceral arteries, extension into the suprarenal aorta, and also to assess vessels for endovascular repair. CT angiography is useful in demonstrating the relationship of the abdominal aortic aneurysm to the renal, visceral, and iliac arteries, and then the pattern of mural thrombus, calcification, or coexisting atherosclerosis, which might influence the repair of this aneurysm. CT can also assess different variants such as inflammatory and mycotic. Then the MRO angiography also has a high accuracy in detecting abdominal aortic aneurysm, measuring diameter, and also helps in planning of treatment for these patients. Now, for natural history, then the abdominal aortic aneurysm gradually expands over years at an average rate of 3.0 to 5.5 centimeter in diameter. It expands at least 0.2 to 0.3 centimeter per year. So the size alone cannot predict rupture. Wall tension, stiffness, and peak wall stress may also contribute. Now, the aortic diameter index to the body surface area may also be a better predictor of rupture for women than diameter alone. And the estimated 1 year risk for rupture is about 10 to 20% for abdominal aortic aneurysm, which about abdominal aortic aneurysm with diameter of 6 to 7 centimeter, 20 to 40% for those with 7 to 8 centimeter, 30 to 50% for more than 8 centimeter. While the 5 year risk for 4 to 5.5 centimeter, 30 to 40% for 5.5 to 6 centimeter. Screening. So the UK recommendation is that screening should be offered to men aged between 65 to 74 years who will receive an abdominal ultrasound. Normal or less than 3 centimeter aorta will not require treatment or further scans, while those with a small size aorta, like 3 to 4.4 centimeter, will require annual ultrasound surveillance and a general practitioner review to optimize lifestyle. For those with medium size, 4.5 to 5.4 centimeter requires quarterly ultrasound surveillance and cardiovascular workup, like a prevention therapy. While those with large, that's greater than or equal to 5.5 centimeter aorta, will be referred for assessment and post repair. So screening of female patients who have never smoked or have a family history is not recommended, as prevalence is lower in females. So treatment, people with small aortic, small abdominal aortic aneurysm can be observed safely with imaging surveillance. Repair to be considered in those who their diameter is more than 5 to 5.5 centimeter in diameter. Then you can also cancel on smoking cessation, statin therapies, in those who have high cardiovascular risk, regular exercise, use of beta blockers, because it helps to reduce them. It helps to decrease aortic elasticity. And then the membrane metalloproteinase inhibitors like doxycycline can also reduce the rate of the expansion of abdominal aortic aneurysm. Optimal medical treatment aims to lower cardiovascular morbidity, slow growth rate, and also reduce peri-operative risk. Angiotensin receptor blocking agents represent a potential alternative blockers in patients with Marfan syndrome. ARBs act on the TGF beta pathway and also accentuate progression of the aortic disease. Other drugs that have undergone animal and clinical testing include the COX-2 anti-inflammatory agents, immunosuppressive agents like rapamycin, but it has not really shown any consistent clinical benefit. Fluoroquinolones should not be discouraged when there is a clinical indication, because the aortic aneurysm/aortic dissection risk increase due to infection itself, regardless.
I'm not hearing her. I don't know if my network.
I think it's the network. I'm checking if she's still on. She's on, but we can't hear her. Oh, let's look on her. I think she's gone off. She's gone off. Let's hope she's able to join soon.
Hello? Can you hear me? Hello?
Yeah, we can hear you now. Just hold on. Let me resume the recording.
I was locked out because of the network.
Only go ahead.
Okay. Okay, so for surgical treatment, aortic root and ascending a supracommissural with a distal anastomosis before the aortic arc, and those below the tubular junction with involvement of the aortic sinus. This approach depends on the aortic annulus. And so if the aortic valve cups apply experience, they recommend aortic valve sparing technique, like reimplantation of the technique. Otherwise, component replacement of the aortic root and valve is indicated. With bioprosthetic valve, we monitor and patients with mechanical and prosthesis. You're not moving. Hello? Dr. Eugene, sorry. The next slide. Okay. I think I'm in the next though.
I've moved, but I think your network.
Hello?
You've already spoken to this slide already.
Okay. Okay. With my laptop, so maybe that's why I think my network took. But can you guys hear me?
Yeah, we can hear you.
Hello?
Yeah, we can hear you.
Okay, so patients with no problem, thank you. So patients with bioprosthetic valve should be monitored by transthoracic echocardiography annually. However, patients with mechanical prosthesis or a native aortic valve, clinical evaluation and transthoracic echocardiography should be monitored, should be performed ASAP if new symptoms develops. So a single antiplatelet therapy with a low dose aspirin should also be considered for the first 3 months after conservative aortic valve surgery if there are no indications for oral anticoagulants. While for those lifelong anticoagulant and therapy with a vitamin K antagonist is recommended for all patients with a benta mechanical prosthesis. In those with a no baseline indication for oral anticoagulants and drugs, low dose aspirin or use of warfarin can be considered in the first 3 months after benta surgery with bioprosthesis. Valve sparing aortic root replacement is recommended in patients with aortic root dilatation if performed in an experienced center, and durable results are expected. Now, patients with dilatation of the tubular ascending aorta. Hello? Hello?
Please go on, we can hear you. I've muted the person.
Okay. So patients with dilatation of the tubular ascending aorta who can be offered surgery with a low predicted risk, the ascending aortic replacement should be considered when they have a maximum diameter of about 52 millimeter. While in those undergoing surgery for tricuspid aortic valve disease who have concomitant dilatation of the aortic root or ascending tubular aorta, ascending root replacement should be considered at maximum diameter of greater than or equal to 4.5 centimeter. The ascending aortic or root replacement may be considered at a maximum diameter in those with greater than or equal to 50 millimeter in patients with proximal aortic dilatation, who can be offered surgery with a low predicted risk and who present with any of the following. Those that present with growth of the aortic diameter of more than or equal to 3 millimeter per year, those with resistant hypertension, short stature less than 1.9 meter, root phenotype, those with aortic length greater than 11 centimeter, those who have desire to be for pregnancy, and those with aortic coarctation. In those with aortic arc aneurysm, surgery for the arc aneurysm are challenging, primarily due to the risk like hypothermic and circulatory arrest and the need for brain protection. So isolated aortic arc surgery is appropriate for asymptomatic degenerative aortic aneurysm in those with more than or equal to 55 millimeter in diameter or symptoms of local compression. Hemi-arc or total arc replacement are frequently required in patients who have an indication for surgery on an adjacent aneurysm of the ascending aorta. While in supra-aortic vessel transposition via off pump the branching followed by TEVA of the arc can also be an alternative to traditional surgery. In patients with thoracic descending aorta at 60 millimeter, that's 6.6 centimeter, a descending thoracic aneurysm and has a 10% annual rupture risk, justify intervention when it's more than or equal to 55 millimeter. Intervention at diameter less than 55 millimeter is better for women with connective tissue disease or rapid growth of more than 10 millimeter per year or more than 5 millimeter every 6 months. Also, thoracic endovascular aortic aneurysm repair is recommended as a first choice intervention for descending thoracic aorta. Thus, open repair is limited to patients with unsuitable anatomy for TEVA or connective tissue disorders. In thoraco-abdominal aortic aneurysm, surgical repair should be considered in patients that have an aneurysma and diameter of more than or equal to 55 millimeter. And in patients with unruptured degenerative thoraco-abdominal aortic aneurysm, suitable anatomy, when elective repair is indicated, endovascular repair using fenestrated or branched endografts can also be considered. Patients with abdominal aortic aneurysm, elective repair is recommended if the AAA diameter is more than or equal to 55 millimeter in women and more than or equal to 55 in men and more than or equal to 50 millimeter in women. In ruptured abdominal aortic aneurysm with suitable anatomy, endovascular repair is recommended over open repair. While in patients with abdominal aortic aneurysm with suitable anatomy and reasonable life expectancy, they can also do EVA can also be considered as a preferred strategy. Elective repair for patients presenting with saccular aneurysm in those with more than or equal to 45 millimeter may be considered. As a way of follow-up, in endovascular treated patients, surveillance aims to detect endoleaks, aneurysma and sac dilatation, graft structure and failure or migration. And after an open repair of thoracic follow up for the first 2 operative days and every 5 years thereafter is recommended if findings are stable. And then after imaging is recommended at 1 and 12 months post-operatively, then yearly until the 5th post-operative year if no abnormalities are recorded. Okay, so endoleaks are defined as persistence of blood flow outside the graft, but it occurs inside the aneurysmal sac, preventing complete thrombosis. And they are the most common complications. There are 5 types, which include type 1, when the blood leaks around the top or bottom of the stent graft, and it requires immediate treatment. The type 2 is when there is blood flow into the aneurysmal sac from other blood vessels. Type 3, when the parts of the stent graft that overlaps become separated. Type 4, blood flow through the pores of the stent graft. And then type 5, described as being due to endotension with an enlarging aneurysm sac without there's no visible endoleaks. And it is recommended to perform 30-day imaging after TEVA by doing a cardiac CT and duplex ultrasound. Also a cardiac ultrasound to assess succession of intervention. Recommended to re-intervene to achieve a seal in patients with type 1 endoleak after TEVA. Now, it's also recommended to re-intervene principally by endovascular means to achieve a seal in patients with type 3 endoleak after TEVA. And then re-intervention should also be considered in patients with type 2 or 4 endoleak. Now, for acute aortic dissection, is a life-threatening medical emergency associated with high rates of morbidity and mortality. It has an estimated annual incidence of 6 per 100,000, with more than 60% of deaths secondary to aortic dissection, which is diagnosed at post-mortem. More than 20% of patients with acute aortic dissection die before reaching the hospital, with more than 50% dying before reaching a specialist center. It has a high early mortality of about 1 to 2% per hour of onset of symptoms. after an acute type A dissection. Okay, the 2-week mortality rate approaches about 75% in patients with undiagnosed aortic dissection, and is said to be documented, is more common in blacks than white, but less common in Asians. 2/3 of aortic dissection occurs in males, likely because of there is a high prevalence of aortic aneurysm in males. Then women usually present at an older age than men. However, patients with Marfan syndrome present earlier, usually in the 3rd and 4th decade of life. Acute aortic dissection also presents with a chronobiological pattern. It has a higher incidence in the morning hours and winter. Aortic dissection is caused by circumferential or less frequently when there's a transverse tear in the intima. It often occurs along the right lateral wall of the ascending aorta, where the shear stress is highest. Another common site is descending thoracic aorta, just below the attachment of the ligamentum arteriosus to the aortic isthmus. The initiating event is a primary intima tear with secondary dissection into the media, or a media hemorrhage that dissects into and rupture the intima. Now, the postnatal aortic flow that dissects along the elastic lamellar plates of the aortic media creates a false lumen, and this is separated from the true lumen by a dissecting or intima flap. Now, the dissection usually propagates distally down the descending aorta and into its major branches, but it may propagate proximal. Distension of the first lumen with blood causes the intima flap to compress the true lumen and narrow its caliber, leading to MAP perfusion syndrome. Okay, so classification is based on anatomical involvement. We have a DeBakey classification, then the Stanford classification. For the DeBakey, we have type 1 to 3, where type 1 is when a dissection originates in the ascending aorta and propagates at least to the aortic arc and often beyond it, distally. The type 2 originates and is confined to the ascending aorta, while the type 3 originates in the descending aorta and extends distally down the aorta or rarely into the aortic arc and ascending aorta. While for the Stanford classification, we have type A and B. Type A is when all the dissection involving the ascending aorta, all the dissection involves the ascending aorta regardless of the site of origin. And then the type B, all dissection aorta but involves other parts of the aorta. Now, 65% of intima tears occur in the ascending aorta, 30% in descending aorta, less than 10% in the aortic arc, and approximately 1% in the abdominal aorta. And we have different classification based on time course, based on ES into when the patient has acute dissection, and then chronic when they present after 90. Have the TAC guidelines where it's acute is less than 14 days, subacute less than 2 to 6 weeks, and then chronic more than 6 weeks. While the international registry aortic dissection classification is divided into the hyperacute phase when the patient presents less than 24 hours, acute 2 to 7 days, subacute 8 to 30 days, and chronic more than 30 days. And disposing factors in congenital factors in combination with to play in the development of aortic dissection. This would include the genetically triggered aortic disease, Marfan syndrome, also congenital cardiac anomaly like the bicuspid aortic valve, supravalvular aortic stenosis, coarctation of the aorta, when there's narrowing of the aorta, and then flow. Then when the patient has atherosclerosis, metabolic syndromes like homocystinuria, familial hypercholesterolemia, inflammatory/infectious disease like patients with giant cell arteritis, Takayasu arteritis, Behçet's disease, aortitis, syphilitic aortic disease, and also long-standing systemic hypertension. 70% have been associated with elevated blood pressure, and that can propagate dissection. Drugs like cocaine, is more common with type B, presenting with abrupt hypertension and small aortic diameter. Also, methamphetamine and also be involved. Pregnancy, occurring in those with underlying aortopathy. About 50% of cases in women less than 40 years have been associated with pregnancy, and most cases occur in the third trimester or early part. Then trauma, when there is a blunt or iatrogenic pumps, cardiac surgery, and then pre-existing aortic aneurysm. Now, the diagnosis requires a high index of suspicion, as no one sign or symptom can positively identify acute aortic dissection. Clinically, the presentation is subject with those affected cardiovascular. The patient will present with chest pain, and they can occur concurrently. And then the chest pain is accompanied by limb weakness or paresthesia. This should alert the patient and the clinician to the possibility of an abdominal aortic dissection. They also can present onset of severe anterior chest or back pain, which is the most classic feature in more than 90% of patients. It's described as a sharp stabbing, tearing, or ripping in nature, a maximum intensity of pain at onset. It also has a migratory character in about 7% of cases, following the path of the dissection through the aorta. Pain may be associated with syncope, MI, and heart failure. Also cerebrovascular accident, when there is impingement of, when the dissection occurs and then there is some form of blockage of blood vessels, like most times in type A aortic aneurysm, because the ascending aorta is the main thing involved. And remember that then the coronary arteries are close to the aortic, the ascending aorta. This flap can impinge on the blood vessel, the coronary artery, and that can lead to an MI. Patients with Marfan syndrome, they can also present with atypical symptoms like burning, pressure, or pleuritic chest pain. Then the anterior chest pain is more common in type A dissections, while back or abdominal pain is more common with type B dissection. The type B dissection has to do with the descending aorta, so it's more common in with abdominal pain. Pain in the neck, throat, jaw, or head predicts involvement of the ascending aorta and often the great vessels. Also, patients can have flank pain, only when they have renal artery involvement. This is seen mostly in patients with type B aortic aneurysm. And they can also present with AKI when there's impingement on the renal artery. Two. Then involvement of the descending aorta can lead to mesenteric ischemia, renal insufficiency, lower extremity ischemia, and spinal cord ischemia. Other clinical features at presentation which are related to complication of the disease include congestive heart failure, coronary occurs in 5 to 10% of patients with type A dissection. Also present with cardiac arrest and sudden death. Then features of compression of by the expanding dissection includes dyspnea, hemoptysis, and business. Possible physical findings on examination include patients presenting looking anxious, in painful distress, and diaphoretic. There can also be a pulse deficit, which is reported in 30% of type A and dissection, 20% of type B, where there is asymmetrical weak or absent coronary break or femoral pulses. Then they can also present with hypertension, which is present in 80% of type B dissection and 36% of type A, with most of the type A presenting with a normal tension. Also, inter-arm blood pressure differential greater than 20 millimeter of mercury raise suspicion of aortic aneurysm, abdominal aortic dissection. 2. Signs of aortic regurgitation like bounding pulses, wide pulse pressure, new diastolic murmurs can also be seen. It occurs in 41 to 76% of patients with type A dissection with a diastolic murmur, audible in about 40%. Finding suggestive of a cardiac tamponade can complicate 9% of type A, where type A dissection, aortic dissection may lead to pericarditis, but commonly a blunt pericardial effusion when there is a leak into the pericardial sac. Or the acute aortic dissection may lead to a left-sided blunt or inflammatory effusion, and then hemothorax may occur mostly from aortic rupture. Patients can also present with neurological deficits like syncope, mental status, peripheral paresthesia, and Horner syndrome. This is normal. The most common abnormality are aortic contour or widening of the aortic, appearing in approximately 70% to 80% of cases. And if you measure the aorta more than 88 centimeters, the carina on AP chest X-ray, pleural effusions, usually left-sided, occur in approximately 20% of section. And then the calcium sign, which is a separation of the location of the aortic intima and the lateral wall of the aortic arch. For ECG, the ECG findings with aortic dissection are not specific, but may, such as small to hemocardium, and the change is suggestive of ischemia may be present in non-specific ST to wave changes. Other tests that are important to evaluate dissection of the complete blood count, comprehensive metabolic profile. For the red blood cell, there could be blood loss, bleeding, and anemia. White cell count, there could be of infection or inflammation. C-reactive protein might also be elevated. Procalcitonin can also be elevated. Creatine can and T may be elevated. When come down with there is can also be elevated, really acute aortic dissection, and it's like a biomarker. It can be elevated in that acute phase. Elevated D-dimer should increase suspicion of aortic dissection. Of D-dimer is immediately very high in aortic dissection compared with other in which D-dimer level is gradually. It's the highest diagnostic value during the first negative D-dimer test at this period increases the alert for possible differential diagnosis. So for diagnostic, the detection of aortic dissection can be established by non-invasive techniques such as the contrast enhanced CT, MRI, and trans-esophageal echocardiography and identify the intima flap and that aortic insufficiency, pericardial effusion, and then with or without tamponade, and then site of entry and re-entry. And this is like a specific sensitivity and specificity comparison for different modalities of investigating aortic dissection. For transthoracic echocardiography, the diagnosis of aortic dissection by standard transthoracic M mode and 2D echocardiography is based on detecting the intima flap in the aorta. Oh. Can you give me a minute? Sorry. Oh? Hello. Hello.
Hello. We can hear you.
Okay, sorry. Can you give me a minute? I need to change position. Where I am, they said they want to lock the place, so I need to change my position. I don't know. I'm coming. Sorry. Okay, sorry about that. Can you guys hear me? Hello? Hello?
I can hear you.
Okay. So I said the transthoracic echocardiography, it's used for diagnosis of the aortic dissection by detecting intima flaps, and the sensitivity of the transthoracic echocardiography to detect type A dissection in about 85 to 90% of patients. And it has a reduced sensitivity for detection. Negative findings does not exclude acute aortic dissection. So this is a picture of the transthoracic echocardiography of a type A aortic dissection. And it's I don't know if you can see this down, the picture down. The arrow pointing to a dilated aortic root. Okay, so this is a plaques view where there is dilated aortic root with an ascending aortic dissection and a severe aortic regurgitation. While for the transesophageal echocardiography, it overcomes the limitation of transthoracic echocardiography. Is of great interest in very unstable patients and can be used to monitor changes in the theater and in post-operative intensive care. It has a better accuracy in the evaluation and diagnosis of acute aortic dissection. And it can be used to detect the intima flap with differential Doppler flow. So this is a table differentiating the true lumen and false lumen. So for size, the true lumen is less than the false lumen, while the false is greater than the true lumen. Then for pulsation, there's systolic expansion and compression, systolic compression for that of the false lumen. Then the direction of flow is if there's contrast agent, there's rapid opacification of the true lumen and delayed opacification of the false lumen. So this is a color Doppler imaging of aortic dissection. You can see the arrow pointing to the intima flap. Intima flaps, and there are differences in blood flow velocity on both sides of the intima flap. So the red color indicates blood flow in the true lumen, while lack of color indicates little or no flow in the false lumen. For contrast enhanced CT, is most commonly used imaging technique for evaluation of aortic dissection, showing two distinct lumens with a visible intima flap. Also, the false lumen usually has a slower flow and a larger diameter than the true lumen. It has a sensitivity and specificity of about 98 to 100% in diagnosing aortic dissection. But the limitations are associated with use of contrast agents, only when patients have nephropathy. So this is a picture of CT scan of an aortic dissection, where you can see the dissection on the ascending aorta, showing a clear flap in the ascending aorta. So this finding is consistent with the type A aortic Stanford aortic dissection. And this is a contrast CT scan of an acute type A aortic dissection. The ascending aorta is dilated and a dissection flap and a compressed and small true lumen. And then there is an expanded false lumen, which is visualized in the ascending aorta. For MRI, it's less often used in initial evaluation of acute aortic syndrome due to longer scanning time. So contraindications with those with metallic implants like all these pacemaker and less overall availability. It's highly accurate in diagnosing acute dissection with a sensitivity and specificity of 98%. And it does not require IV iodinated contrast material or ionizing radiation. Gadolinium contrast must be used with caution in those with reduced kidney function due to the risk of nephrogenic systemic fibrosis. Also, non-contrast enhanced MRA may diagnose aortic dissection when gadolinium contrast is contraindicated. It can also detect blood flow, which may be useful in characterizing anterograde versus retrograde dissection. Aortography is used less commonly now because of the accuracy of other non-invasive techniques, but may detect dissection after coronary angio has been performed in patients for whom acute coronary syndrome was initially suspected. So this is like a recommendation of everything that will be supposed for treatment of patients with aortic dissection. ICU admission is important for hemodynamic monitoring, patient stabilization, pain control, and lowering of blood pressure are the goals in the acute setting. Unless contraindicated, a beta-adrenergic blocker should be administered parenterally using maybe intravenous labetalol, metoprolol, or short-acting esomolol to achieve a heart rate of 60 to 80 beats per minute. And this should be accompanied by intravenous sodium nitroprusside infusion, which is used to lower systolic blood pressure to 120 millimeter of mercury, or the lowest level necessary for adequate perfusion. Verapamil or diatazam may be considered for heart rate in those who have contraindication to the use of beta blockers. Also, enalaprate plus a beta blocker can also be considered in blood pressure monitoring, in blood pressure control. Pain management, narcotics or opiates are the preferred agents, and beta blockers should be used with caution in settings of acute aortic regurgitation because they block compensatory tachycardia or suspected cardiac tamponade. Emergent or urgent surgical correction is preferred treatment for those with acute ascending aortic dissection, intramural hematomas.
Hello, Dr. Eugene, the slide is not moving. I don't know.
I'm working on it.
All right, okay. Sorry, Dr. Lillian, you can go ahead.
Okay, so you go to the next slide. Next. Okay, so I said emergent or urgent surgical correction is the preferred treatment for acute ascending aortic dissection, those with intramural hematomas, and for those with complicated type B dissection, including those characterized by propagation, shock, or MAP perfusion, where open surgical surgery this can also be offered. In hypotensive patients, intravenous fluid administration is a reasonable first approach. Then vasopressors can be added if needed to maintain adequate perfusion, but may cause further forced lumen propagation. Inotropic agents should be avoided as they are likely to increase the force and rate of ventricular contraction and therefore worsen aortic wall stress. Pericardiocentesis for acute hemopericardium in patients with cardiac tamponade require caution that this may result in recurrent bleeding and acute hemodynamic collapse, especially if a large volume of fluid is removed. For surgical management, surgery involves excision of the intima flap, obliteration of entry into the first lumen proximally and distally, and reconstitution of the aorta with interposition of a synthetic vascular graft. A composite valve graft conduit is used if the aortic valve is disrupted. Overall, in hospital mortality rate after surgical treatment of patients with type A aortic dissection is reported in approximately 18% compared to 15% mortality for those that are medically treated. Okay, so the IRAD registry, that's International Registry for Acute Aortic Dissection, it reported a 26% mortality in surgically treated type A aortic dissection compared to 58% mortality in those who were treated medically. So the major causes of perioperative mortality and morbidity include myocardial infarction, those with paraplegia, renal failure, tamponade, hemorrhage, and sepsis. So indications for thoracic endovascular aortic repair for complicated type B aortic dissection is when the patient has rupture or has an impending rupture, MAP perfusion syndrome, hemothorax, when there's refractory pain or retrograde extension of the dissection into the ascending aorta, refractory hypertension, aneurysmal dilatation more than 55 to 60 millimeter, and progressive aortic enlargement of more than 5 to 10 millimeter per year, and then recurrent symptoms. For uncomplicated and stable distal dissections and intramural hematomas, medical treatment is the preferred. Acute type B aortic dissection has a lower acute mortality rate than those with an acute type A dissection, with an overall in-hospital mortality rate of approximately 10%. The in-hospital mortality for uncomplicated type B aortic dissection is approximately 1 to 6%, but higher in complicated, especially when accompanied by shock or rupture. So for long-term management of patients with acute aortic dissection, it consists of control of hypertension, serial imaging of the aorta, screening of the patient, and then first-degree relatives for heritable disease, lifestyle modification, education, and social support. For the control of hypertension, blood pressure goal of less than 120/80, beta blocker is the first choice antihypertensive because it reduces aortic wall stress, and it's recommended even without hypertension. It can be used with other antihypertensive like ACI or CCB where necessary. Poorly controlled hypertension is associated with an increase in late morbidity and mortality. For patients that have TEVA or surgical thoracic aortic repair, first follow-up with either CT or MRI should be performed at 1 month after treatment to exclude the presence of early complications. Surveillance should be repeated after 6 months, 12 months, and then yearly. For patients with chronic type B dissection, primary receiving medical therapy, surveillance should be performed 6 months after initial diagnosis. And then if there's progressive descending aortic enlargement, more than 5 to 10 millimeter per year, or aortic diameter greater than 55 to 60 millimeter, these are the risk factors for rupture, and such should be evaluated for repair. Long-term prognosis for patients treated for dissection is generally good with a careful follow-up with a 10-year survival rate of approximately 60%. Markers of poor prognosis in acute aortic dissection are when they have hypotension or shock, acute heart failure, acute MI, cardiac tamponade, age greater than 70 years, when there's preoperative neurological impairment, renal or visceral ischemia, renal failure, when there's abnormal EKG, particularly when they have ST elevation, and then if there's a great extent of the aortic dissection. Then for chronic aortic dissection, there are 2 clinical patterns of chronic aortic dissection. Patients with an initial acute aortic dissection entering the chronic phase of the disease, and those in whom first diagnosis of chronic aortic dissection is made by an incidental finding, because these people are usually asymptomatic. In such patients, symptoms related to the enlarging dissected aorta, like hoarseness of voice, dysphagia, or chronic visceral malperfusion, just coming down with abdominal pain, claudication, altered renal function, or acute chest pain, indicating a rupture or worsening dissection will be sought for. Chronic aortic dissection is suggested by imaging characteristics of thickened immobile intima flap, presence of thrombus in the first lumen, or aneurysm of the thoracic aorta. And indications for surgery in chronic type A aortic dissection is recommended for appropriate candidates, especially in the young and those with an ascending aortic aneurysm greater than 5 to 5.5 centimeter, those with aortic regurgitation or other symptoms. Contrast CT or MRI is also recommended to confirm the diagnosis of chronic aortic dissection. And then initial close imaging surveillance for patients with chronic aortic dissection is indicated to detect signs of complications as soon as possible. Then there is what we call the aortic intramural hematoma. Is defined as a hematoma within the medial layer of the aortic wall in the absence of any identifiable communication between the lumen and the hematoma. And there's no evidence of intima flap or first lumen. It represents 10 to 20% of acute aortic syndrome. And it involves the aortic and the ascending aorta in 30%, the arc in 10%, and descending aorta in 60 to 70%. It can result from rupture of the vasa vasorum in the adventitia and subsequent mural hemorrhage into the tunica media. This hematoma is located at the outer medial wall in contrast to the inner medial location of a classical aortic dissection. So imaging studies useful for diagnosis of intramural hematoma include the transesophageal echocardiography, CT or MRI. For detection of the acute aortic intramural hematoma, transthoracic echocardiography is inadequate because of its low sensitivity and is diagnosed in the presence of a circular or crescent-shaped thickening of more than 5 millimeters of the aortic wall in the absence of detectable blood flow and intima flap. So this is a picture of an acute type A intramural hematoma of the aorta. This is a transesophageal echocardiogram showing the thickening of the ascending aorta. That's the picture on the right due to intramural hemorrhage. These are CT findings of intramural hematoma of the aorta, where there is the blood products have intermediate intensity with a T1 weighting and hyperintensity with T2 weighting corresponding to oxyhemoglobin. Okay. So predictor of intramural hematoma complications include persistent and recurrent pain despite aggressive medical therapy, difficult blood pressure control, ascending aortic involvement, when there is maximum aortic diameter of more than 50 millimeters, progressive aortic wall thickness, enlarging aortic diameter, recurrent pleural effusion, penetrating ulcer or ulcer-like projections, which are secondary to localized dissection in the involved segments. So in all patients with intramural hematoma, medical therapy, including pain relief and blood pressure control, is recommended. While in case of type A intramural hematoma, urgent surgery is indicated. In the case of type B, initial medical therapy under careful surveillance is indicated. And then in uncomplicated type B, repetitive imaging is also a class 1 is indicated. In complicated type B, TEVA can also should be considered, while in complicated type B, intramural hematoma, surgery should be considered. Then the penetrating atherosclerotic aortic ulcer, they are atherosclerotic lesions with ulceration that penetrates into the aortic wall, usually localized and are not associated with extensive propagation. It represents 5% of acute aortic syndrome. It may be single or multiple and range from 5 to 25 millimeters in diameter and 4 to 30 millimeters in depth. It's found primarily in the mid to distal descending thoracic aorta than arc and the abdominal aorta. It's rarely seen in the ascending aorta. And this is seen typically in older adults with coexisting cardiovascular risk factors and disease. And it can be 25% of it can be found incidentally on imaging studies. Most patients do not have aortic regurgitation, pulse deficit, and then signs of organ perfusion or ischemia. And then propagation of the ulcerative force may either lead to intramural hematoma, pseudoaneurysm, rupture, or an acute aortic dissection. For pathogenesis, it's due to atherosclerotic plaque that erodes through the intimal layer of the aortic wall in the medial layer. It has a direct communication between the aortic lumen and the medial layer of the wall, and is usually associated with intramural hematoma. Investigations include CT, MRI, transesophageal echocardiogram, and aortography. Of this, contrast-enhanced CT is the imaging technique of choice for diagnosis of penetrating atherosclerotic ulcers. And on an unenhanced CT, it may resemble an intramural hematoma. Findings on CT include a localized aortic ulceration, a calcified displaced intima, and then it can have a coexisting aneurysm or intramural hematoma. So predictors of disease progression include increasing aortic wall thickness when they have an ulcer greater than 15 to 20 millimeter in diameter or greater than 10 millimeter in depth, increasing aortic hematoma, and increasing pleural effusion. So this is a CT demonstrating an acute penetrating atherosclerotic ulcer. It's an Asia image which demonstrates the typical focal output pattern of the aortic ulcer. That's the first picture. So for management of penetrating aortic ulcer, medical therapy, including pain and relief and blood pressure control, is recommended. While in those with type A, penetrating aortic ulcer, surgery should be considered. In the case of type B, initial medical therapy under careful surveillance is recommended. In uncomplicated type B, repetitive imaging is indicated. In complicated type B, TEVA should be considered, and in complicated type B, surgery may also be considered. Thank you. Hello? Hello?
Very much, Dr. Lillian Ogekile. Currently, we let's show our appreciation for the presentation, quite extensive. Thank you for this presentation. At this point, we want to welcome contributions, questions. We can unmute and ask our question, or we put it in the chat box. Any question, please, and contributions. Okay, whilst we wait for questions and contributions, consultants on the call, any contributions, directions on what to expect, how to approach questions with respect to aorta and its associated disease. Before then, my comment is, whilst we wait for consultants' contribution or questions, I noticed you used the 2014 ESC guidelines in parts of your slides. Just to let you know that there was an update together with the peripheral arterial disease for the 2024. So later on, we'll have to look at that.
Okay.
Okay, so it appears you have exhausted all the possible contributions and questions. Thank you very much, Dr. Lillian Ogekile, for this presentation. We'll move on to
Dr. Lillian.
Okay.
Dr. Lillian, let me just ask one very funny MCQ question to her. Dr. Lillian, thank you so much for a very extensive, very, very extensive. I really enjoy it. You touched almost all areas. So I think this slide should be on the platform so that we can squeeze it in. You answered a whole lot of MCQ questions. When we get to that part of Broward, you find out that you touched most of the MCQ questions, the later parts. And also some of the MCQ questions we'll be doing after Broward. Have you, just some few questions, really grateful for the time you spent to put this together. Did you read through syphilitic aortic aneurysm specifically?
No.
Okay, so let me just make. Okay, it would be great to look at it because, of course, some kind of funny questions usually come. Syphilitic aortic aneurysm is that aneurysm that we know can rupture but never dissect. I don't know why, but it has that angiom of it rupturing but never dissecting. Of course, it has the circular form.
Yeah.
It ruptures, but it never dissects. So it's really nice to keep that in place. And then it has two angioms, aneurysm of signs and aneurysm of symptoms. When it affects the ascending aorta, it is termed the aneurysm of signs. And if it affects the arc of the aorta, it's the aneurysm of symptoms. Of course, they all have classical manifestations. And he said it rarely affects the abdominal aorta, but it mostly affects the arc of the aorta, the ascending aorta, arc of the aorta, and then descending and least commonly affecting the abdominal aorta. I think so. Probably you just check aneurysm of signs
Okay, sir.
and aneurysm of symptoms. When it affects the ascending aorta, it is termed aneurysm of signs.
Okay.
And when it affects the arc of the aorta, it's termed aneurysm of symptoms. Each of them are classical manifestations. One affecting the anterior, the sternum. The aneurysm of signs, that's the one affecting the ascending aorta, cause some erosion of the anterior sternum, and you can see some pulsation even on the anterior chest wall. Of course, it compresses the SVC, superior vena cava, cause some form of RVOT obstruction symptoms. Why that of the aneurysm of symptoms, the arc of the aorta, affects the vertebra behind, and also affects the more or less have more of nervous involvement, hoarseness of voice that looks like Horner syndrome. I think that's what just check up syphilitic aortitis.
Thank you, sir.
Thank you very much. That was great. Well done.
Thank you.
So, Dr. Eugene, over to you, please.
Thank you, sir. So we are going to the second part of our presentation, the MCQs. So kindly let's ensure we are on and we are ready to answer. Dr. Charles Okori will share the slides on that soon.